So I'll get started. Good morning, everyone. For those who don't know me, I'm Fedaa Najdawi. I'm Director of Pathology at PathAI. And first of all, thank you all for joining today. And for people who are going to be listening to the recording later on, thank you as well for getting involved in this initiative. The idea here, or what we're trying to do, is to get people accustomed to a qualitative evaluation of our IBD-Explore tissue models. So today, what I will be doing is going over an intro to what IBD-Explore. A lot of the people on the call might have been already involved with the development of these models, but you'll notice there are some differences in terms of the colors of the overlays, but we'll go over that. Then we'll cover the qualitative evaluation and the actual procedure for accurate evaluation, including, what different substances mean and how to evaluate them with some cases. But essentially, if you have any questions throughout the presentation, please add them in the chat. And what I will do toward the end of the presentation, I'll go over these and address them. To start with, what I will cover now is what is IBD-Explore. Essentially, IBD-Explore is an AI-powered panel from which we extract human interpretable features on the overall whole slide image. And the purpose of that is to characterize the inflammatory microenvironment of ulcerative colitis mucosal biopsies. And so we have multiple models that kind of in that umbrella of IBD-Explore. We have the artifact model, the tissue segmentation model. We have the goblet mucin model, as well as the cell overlay. Essentially, what we will be asking you to evaluate are the tissue models. So the artifact, the tissue segmentation, and the goblet mucin, but not the cell overlays at this stage. From IBD-Explore HIFs that I just mentioned, what we do is we characterize, as I mentioned, the inflammatory microenvironment. And this characterization is really spatial and on a single cell resolution. And the idea here is that we get those HIFs, we analyze them and correlate them to certain outcomes, treatment response, any kind of endpoint of interest that we want to look for insight from the H&E that the human eye cannot get at. And so we analyze these, we gain insight with the hope that this IBD-Explore product is going to help push the precision medicine in area of IBD. And the output from every whole slide image is a structured panel of over 600 HIFs or features that combine the cell and tissue overlays. And so it's really critical to make sure that we assess the performance of this model on each whole slide image. And that is the purpose of what we're going over today, is really to try and get a high quality output or high quality data from each of these whole slide images by assessing the model performance. In terms of the qualitative evaluation, as I mentioned, this is really aimed to characterize the performance of the artifact and tissue model on each deployment. So we want to comprehensively and accurately evaluate the model performance across different samples. We want to gain feedback in terms of the model performance per slide. And then what we do is we aggregate the overall performance in data sets of interest. The slide evaluation task itself might be variable in terms of how long it might take, but we expect 4 to 5 minutes per slide for the task to be completed. Now, for the models themselves, these are all tissue models. What I mean by tissue models, they're going to segment tissue regions and not identify cells. So the first one for evaluation would be the artifact model, and that will segment background separate to areas of artifact. Background would be any areas with no tissue in the background of the slide. It might also have background predictions in areas where there are tissue cracks, and that is expected, but that would not or should not include crypt lumen or blood vessel lumen. And then artifact would be any area of actual artifacts that hinder the tissue unevaluable. So areas of crush or blur that will prevent you from making any kind of call or assessment in that specific region. And then we have the goblet mucin model, and that will output two things. So it will segment regions of goblet cell mucin. And when I say goblet cell mucin, it will only segment the mucin within the cytoplasm of goblet cells. So it will not be covering anything else, not mucin in the crypt lumen, not mucin outside of that. So it's only in the cytoplasm of the goblet cell itself. And then additionally, we have predictions of the blood vessel lumen, and that will be only blood vessels that have a lumen that you can see on the H&E. So you won't get a prediction in areas where there are compressed lumen, where you can't see the actual lumen itself. And this is just a close-up on the goblet cell mucin model. For the tissue segmentation model, this would be similar to what you have been exposed to previously. The only difference here is that the color scheme is different in terms of what each substance color is. But essentially what it segments is areas of epithelium. So you'll have areas of normal epithelium, areas of infiltrated epithelium. Infiltrated epithelium is any epithelium that has at least one neutrophil in it. And so here, having intraepithelial lymphocytes or eosinophils within the epithelium does not apply. And then you have crypt lumen, you have crypt abscess, in which the model is going to predict any crypt with at least one neutrophil in the crypt lumen as a crypt abscess. And I will go over specification for each of these substances as we go through the presentation so that it can help you understand how to assess each of these substances separately. We also segment muscularis mucosa, lamina propria, erosion ulceration, blood vessels, and granulation tissue. And these are all the substances that you will be required to assess when you do the qualitative evaluation. We do have prediction of other tissue on the slide, but you won't be required to assess the performance on that. So what do we mean by qualitative QC, or what is the workflow there? What we suggest in terms of the workflow itself, because we're requesting from you multiple different evaluation tasks, we want you to assess first the sample evaluability, and I will go over what that means. We want you to assess the artifact model, and that would be the artifact in the background. We want you to assess the goblet mucin model, as well as the tissue region or segmentation model. And what we would suggest is to start with the QC step and then go to the artifact model, because essentially when you are reviewing the other two tissue models, you will need to exclude areas of artifact or background from the evaluation of performance, because essentially the model is designed to mask these areas, and you won't see downstream prediction of the tissue models, the two tissue models in these areas, saying that these has to be true areas of artifact and not kind of an error masked. Now, when you are reviewing, we want you to please make sure that to move around the slide and zoom in and out as you are evaluating the substance performance. And that's to make sure your evaluation is comprehensive. So when you're evaluating a certain substance, that's not based on one biopsy or one level. It should be based on the entire whole slide image, so the entire tissue region on the slide. In terms of miscalls, please remember that miscalls in one substance will result in miscalls in another substance. So for example, if you have erosion ulceration overcall in lamina propria, then eventually that is going to result in a lower recall of lamina propria, but also a lower precision in erosion ulceration. So kind of consider these iteratively. If you have ranked performance of a substance below 80%, and I'll go over how we're ranking each substances or what is the actual percentage rank, your comments would be really immensely helpful. We would appreciate any feedback we get from you, because it will help us monitor the model performance. So it's not just if you feel that the model performance on that specific slide is lower, so below 80%, but also if you see any repeated errors. So anything that appears to be systematic, even if it was really minute. So for example, if you see there is overcall of granulation tissue, really very tiny overcall, but repeatedly you see the same overcall over multiple slides, then feedback kind of from that perspective is also very helpful for us, and we would appreciate it. For the first task, which is a sample evaluability, the question here is the sample evaluable? And what we mean by that is, can we assess the biopsy to give a score, a downstream score of the different compartments, the kind of the inflammation of the tissue, the architecture of the tissue. And you can think about it the same fashion that you would approach a clinical sample. So when you have a biopsy from a colon, if there is no sufficient surface epithelium, crypt, and lamina propria, then it won't be evaluable. And so we ask that you approach the biopsy in a similar fashion here. And so if there are sufficient surface epithelium, crypt, and lamina propria on the slide for histological assessment that is in focus and not obscured by artifacts, then you can give a yes. But keep in mind that for some biopsy, you might only get ulcer bed. The sample in that instance is also considered evaluable, but we do request that you mark this as yes, but evaluable to include ulcer bed only. Now, if that does not apply, this is not the case, then you can mark the sample as not evaluable. And we gave you multiple options in terms of why you think this sample is not evaluable. And that includes things from, artifacts obscuring the entire tissue area or most of the tissue that is not, that kind of hinder the entire sample unevaluable, or, some scanning artifacts rendering the tissue out of focus. If there is minimal or insufficient tissue, including biopsies that are superficial, so only the kind of the superficial epithelium is present, or if there is any other reasons, it's really the wrong tissue is submitted, or this is a resection specimen rather than a biopsy. In that case, we'll give you a free text to enter what you think is a reason for the sample being unevaluable. This is an example of a slide that is not evaluable because of crush artifacts. You can't really see the tissue in that region. You can't really assess anything. And here, the tissue is scant, but it is also out of focus, and there's a lot of crush artifact as well. If you have multiple reasons why the tissue is unevaluable, just select the prominent one. But if you cannot really evaluate the tissue, then we want it to be marked as such. Now, after doing task 1, then the downstream task 2, 3, and 4 are really model performance evaluation. And what we're asking for here is to assess both recall and precision of the model predictions. Recall or sensitivity is really looking at, out of an actual tissue area, what fraction did the model correctly identify? So if you have lamina propria, what fraction of that lamina propria did the model actually identify and call as lamina propria? While precision, on the other hand, is out of all the substance predicted by the model, what fraction is correctly identified? And so if you have the model prediction of lamina propria, you have to look at that area predicted as lamina propria and see what fraction of that is actually the substance that is predicted, or lamina propria. Now, in terms of, as I mentioned, we are giving you options to choose from in terms of the percentage of, the model prediction, the sensitivity, as well as the precision. And these will be the ranges that are listed here. So for recall, we want you to look at the actual true positive rate of a substance prediction. And if the substance is not present on the slide, then you can choose NA. So here I'm not talking about the model prediction, but rather the actual tissue region. If it's not present on the slide, then the recall should be NA. For precision is really the positive predictive value of substance prediction. So what you're looking at is the model prediction of a substance, and then you're giving the precision kind of with these ranges, depending on how the model is performing on a slide. If there is no model prediction of a certain substance, then you can choose NA. We'll go over over some examples to explain that a little bit more. So, I mean, the way that you would approach it is you would look at the biopsy first. So pathologists can decide whether a certain substance is or tissue area is present or absent. Now, if that tissue region is present, then you would look at the model prediction. Did the model predict the presence of a substance? If that's the case, and the model did predict a substance that you deem that you determine that is present, then you can evaluate recall and precision according to the overlap between the two. And so you would evaluate recall by looking at how well the model captures kind of the area of this substance, and then look at or evaluate precision by looking at how precise the model prediction of that substance. Now, if you deemed that there is a certain substance or tissue region, and the model erroneously predicted the absence of that substance, then automatically recall would be 0 to 10%, because the model missed the entire region of the substance. On the other hand, precision itself is NA. And that's, as we said previously, that is based on the model prediction. There is no model prediction of this substance. Now, on the other hand, if the pathologist evaluated the biopsy and determined that there was no substance, like, for example, there's no granulation tissue in this biopsy, and the model predicted the presence of such substance, then automatically precision would be 0 to 10%, so the lowest range. And that's because all the model predictions of that substance is actually erroneous. On the other hand, recall, which is kind of looking at the presence of a tissue region or a substance, is NA, because this substance is not present on the slide. If the model accurately predicted the absence of such substance, then both recall and precision would be NA. Now, as I mentioned, for the first option, if the pathologists think that there is a certain substance or tissue region, and the model predicted the presence of that substance, then that overlap will help determine recall and precision. If there is a predicted substance and the model, predicted the presence of that specific substance, but the prediction and the actual region do not overlap, then both recall and precision for that would be the lowest, and that would be a 0 to 10%. And so out of this kind of more qualitative but quantitative evaluation, we will use that to classify the model performance on a whole slide image. So we can say that the model performance for a specific substance is excellent, good, and so forth, until we kind of deem it poor if there is both over and underestimation. And this is really based on the percentages that you choose, based on the overlap between the model prediction and the actual presence or absence of a substance or tissue region. Now, these are some practical recommendations in terms of how you would approach the whole slide image. We would recommend that you start, as I mentioned, with the evaluation of the sample. If it's non-evaluable, please do evaluate substances that are present. So what I mean by that is, let's say the biopsy was deemed unevaluable because it was superficial and you only have the superficial epithelium. So you can't really, give a call of chronic active, whatever. You can't really assess the biopsy properly because it's superficial. We would still want evaluation on that superficial epithelium. How did the model perform on that epithelium? So we can get, an idea of how the model performs even on these, unevaluable slides overall. If the substance is not present or could not be evaluated, then you can use NA for that. Now, in terms of the suggested order of evaluation, I said background and artifact would be the first thing to start with, because you need to exclude these areas from downstream evaluation of the other tissue overlays. For the tissue segmentation model, what we recommend is assessing each substance or tissue region separately by hiding predictions of all other substances. And you'll see how it's really easier to look at one substance at a time because the tissue segmentation model segment many different regions on the slide. And make sure to move around the slide and zoom in and out in different regions, because your evaluation is really not based on one level and not based on one tissue region, but on the entire slide. So this is an example of, if you turn on all the models, the tissue segmentation, the artifact model, and the goblet mucin model, this is how the overlays would look. And it would be really hard to evaluate each substance per se, just by looking at everything together. And even if you zoom in, it's sometimes really hard to make sure that, the segmentation itself is correct. We're not masking things that shouldn't be masked. There is no overlap between certain substances. And you'll see it's much easier to look at one model at a time, one substance at a time. What I would recommend is to have a side-by-side view, and you can do that by pressing where the red arrow is pointing, to have your H&E slide, whole slide image on one side, and then another H&E slide, whole slide image on one side with a single overlay turned on. And so here you can see the artifact model with an excellent performance. As expected, the background is masked. It's masking some of the tissue cracks, but it's not masking the lumen of the crypt, which is what we would expect. The artifact model itself is masking areas of crush or blur. And so it's doing what is expected to do. And for that, the performance for both recall and precision would be excellent, or within the range of 90 to 100%. Here we see overcall of background. And yes, the background should be predicted in tissue cracks. But if you look in this area here, you can see that the background is being overcalled in lamina propria. And so if you look at the entire tissue, kind of the entire region, you can see that the model picked up all the area of background. So for that, recall or sensitivity would be really excellent, 91 to 100%, but the precision would be lower. And because the overcall kind of percentage over the entire area that is predicted as background is somewhere between 10 to 15%, then the precision would be somewhere between 81 and 90%. And that's an estimation based on, as I said, the entire slide and not just one region. After you've finished assessing the artifact model, then you can move on to the goblet cell mucin model. As I mentioned, the goblet cell mucin is expected to highlight only the mucin in the cytoplasm. So it should not be predicting the nucleus, it should not be highlighting the nucleus, it should not be highlighting any mucin within the lumen. It's only the mucin within the cytoplasm and not really the entire cytoplasm. So just the areas of the goblet itself where you have the mucin. The blood vessel lumen will highlight the vessels which has a lumen and not those that are compressed. So you shouldn't be seeing any kind of prediction of these two substances in any lumens, like crypt lumen, or in tissue cracks, which is what we're seeing here. We're seeing both really excellent recall and precision. Now, here is a kind of a comparison or a contrast between looking at everything together and just picking one tissue region or substance and assessing that separately. So here is how I would suggest assessing the tissue model, and that's really specifically more applicable for the tissue model because there are many different substances at once. That's what I would suggest we approach the whole slide image. We hide all the predictions, and I here left the normal epithelium, and it's really easy to see that the model is picking up all the areas of normal epithelium. So that's all the areas that has epithelium with no associated neutrophil, so no intraepithelial neutrophil. And it should not be predicting the crypt lumen as epithelium. And you can see that's the case here. So both recall and precision here are really excellent. For lamina propria, the model should pick up or predict lamina propria in an area that corresponds to lamina propria. I would say here, just keep in mind that areas of blood vessels will be predicted separately as a separate substance. So just keep that in mind when you're assessing lamina propria. Also, if you have areas of lymphoid aggregates or areas where there is, lymphoid follicles, this will be predicted as other tissue and should not be, accounted for when you're assessing the lamina propria performance or the model performance on lamina propria. So if you look at this tissue here, we can see that the model is doing really excellent for both recall and precision. There's no overcall or undercall. And here's the blood vessels I mentioned. This will predict areas of blood vessels within the lamina propria and outside the lamina propria. So if you have blood vessels in the submucosa, if there is submucosa in the tissue biopsy, then it will also be predicted there. Or if there's granulation tissue, then the blood vessels within granulation tissue should be predicted as blood vessels. And you assess the blood vessel prediction everywhere on the slide and not just in one tissue region or one biopsy. This kind of hiding all the substances and leaving one on the slide is really helpful as well when you don't have or you don't expect to see a certain substance on a slide. So for example, this biopsy here does not show any active disease. And so you should not be expected to see any infiltrated epithelium. And this can be easily seen that there's no prediction whatsoever on the left-hand side, which means both precision and recall are NA. And that's, as we said, kind of recall is really, is the actual substance present on the slide? And it's not. And then precision, did the model predict any area of that substance? And we don't see any prediction. And so for both, it would be NA. This is another example for crypt lumen. So for crypt lumen, it's intuitive is kind of the lumen within the crypt that will be predicted as such. And you can see here, it's picking up on all of the areas that should be predicted as such. And so both recall and precision are excellent. And we don't see any overcall in, outside the crypt lumen or on the surface. This is another biopsy where we see a crypt abscess. So for that, the model is picking that single focus on the entire slide. That is actually a crypt abscess with rupture, and it's kind of highlighting that entire area. For crypt abscess, the model is expected to predict any crypt with at least a neutrophil inside the lumen as crypt abscess. And so for this case here, because there's only one crypt and the model is picking it up, so the substance is present, the model is predicting that substance, and both the area and the model prediction overlap completely. So both recall and precision are excellent. What I want to point out, though, is that the way the model has been trained to identify crypt abscess is to identify the crypt lumen with at least a neutrophil and then highlight the epithelium surrounding it. But it's not necessarily going to highlight the entire crypt epithelium surrounding that region. So the way that I would approach this is if it's really a crypt abscess and it's selecting some of the epithelium around it, even if it's not complete, then that performance is as expected. The way that you would approach the residual epithelium around is it should be segmented based on whether it has neutrophil or if it's not. So in areas where there is neutrophil infiltration, this should be predicted as infiltrated epithelium. So you should see at least one neutrophil in this area. If there is no neutrophil, then that should be predicted as normal epithelium. And you can turn that off and take a look and assess that separately. But for the crypt abscess itself, this is what we would expect from the model performance, because this is the way that we trained the model and we want it to be assessed. Saying that, when you are looking to evaluate crypt abscess on a whole slide image, you want to make sure that you're looking at all areas predicted as crypt abscess. And so, for example, in this case, there are multiple crypt abscesses predicted. And if you zoom in many of these areas, the model is doing a great job picking up these crypt abscesses. But in one of them, there is an error in terms of the prediction and overcall of a crypt abscess in area where there's some telescoping. And so for that instance, if we think about recall, it's picking up all the crypt abscesses. So it's doing really good job at kind of in terms of sensitivity, and the recall would be 91 to 100%. But because it's overcalling in that one focus, we consider, you know, the entire surface area that is being predicted as crypt abscess, and what percentage of this prediction, what is the percentage of this prediction compared or over that entire area. And so for that, this would be somewhere between 10 to 15%. And I'm not talking about the entire tissue itself, like not the entire biopsy, but the entire area predicted as crypt abscess. And so precision here would be somewhere between 81 to 90%. For infiltrated epithelium, as I mentioned, this is really epithelium that is infiltrated with neutrophil. So that does not apply for apoptotic debris. It does not apply for intraepithelial lymphocytes, and it does not apply for eosinophils. Saying that, if you have an eosinophil or an apoptotic debris or an intraepithelial lymphocytes, but you still have an adjacent neutrophil, it would still qualify. So really, you base the whether the prediction is correct or not on the presence or absence of neutrophil in that specific area. And when you're looking at, assessing the normal versus infiltrated epithelium, it's easier to look at them separately as any of the other substances. It's also good to keep in mind that for the crypts, not just for the surface epithelium, the crypt is going to have kind of both predictions, depending on whether there is a neutrophil in the epithelium or their absence of neutrophil in the epithelium. And so if we zoom in here, you can see that the infiltrated epithelium prediction correspond to areas where there are neutrophil in the epithelium. And if you turn off the normal epithelium overlay color, it will be easier to actually look and see. As one would expect, the yellow regions, which are infiltrated epithelium, should have neutrophil. If you see any neutrophil in areas that should have been predicted as normal epithelium, then that's a miscall or an undercall of infiltrated epithelium. But we do see that, the model is picking up any area that has a single neutrophil in the epithelium and is not missing any of that areas with neutrophil in that area. So both recall is really excellent, and precision in terms of, it's not overcalling infiltrated epithelium in areas where there is no neutrophil is also excellent in this case. And you can also kind of toggle on and off between the two, which will make it easier to kind of assess infiltrated versus normal. In terms of granulation tissue itself is really a feature that you would see if there was epithelial destruction in a way. So you would see granulation tissue if you have an ulcer at the base of the ulcer, or if you have, a large crypt with rupture and associated kind of loss of epithelium and injury in the lamina propria. And so what you would expect to see is that these neovascularization with plumb endothelial cells with associated inflammation. And this is what the model is highlighting here in black as granulation tissue. Now, the vessels, as I mentioned, will be predicted separately as such, although they are within the vicinity of the kind of the area of the granulation tissue. The erosion ulceration, the way the model or kind of that substance label itself is really the surface of the ulcer in this case, in this example here. So it's really the fibrinopurulent exudate on the surface of the ulcer. It might overlap with the surface area of the granulation tissue because this is the way that the model was trained. But it also includes kind of this superficial erosion. So it doesn't, it's not always going to be in association with granulation tissue. You'll get cases where there is prediction of erosion ulceration where there is actually just superficial erosion. What I want you to pay attention for is we don't want the model to overcall these in areas where there is no true erosion. So really you need to have loss of epithelium with this surface fibrin that is associated with active inflammation rather than anything else. And this is how you would approach an erosion. And then if you have an underlying granulation tissue and you see the fibrinopurulent exudate, then this is clearly an ulcer and it's easier to assess. But just keeping that in mind when you're assessing erosion ulceration. So this is kind of a close-up look at the junction between the two, but we still, the performance here is really excellent. One thing to keep in mind, as I mentioned, the model, we will not ask you to assess performance on other tissue, but it's something that we want you to keep an eye for because we don't want these areas included in the assessment, or we want you to account for these when you're assessing other tissue regions. So other tissue would include submucosa. It will also include lymphoid aggregates or areas of lymphoid follicles within the tissue. You might also see some other tissue prediction where there is mucin or debris on the surface that does not qualify as erosion ulceration. So you have intact epithelium here. So all these areas will be predicted as other tissue, and we just want you to account for that when you're looking at the predictions or assessing the predictions of all the other substances. And that is important when you're looking at an ulcer, for example, where you might see at the base of the ulcer some lymphoid aggregates. You will see that the model is calling these lymphoid aggregates as other tissue while predicting the actual area of granulation tissue as such. So just keep that in mind when you're looking at the tissue. So kind of going back, when you're looking at the slide, try to assess the performance of the model on a certain substance on the whole slide. So as you see here, even from low power, you can see there is, this is clearly an ulcerated epithelium. And you can see that the model is picking up on the fibrinopurulent exudate across the slide. And if you kind of start to zoom in and look in a few different areas, you can see it's nicely identifying areas of fibrinopurulent exudate as erosion/ulceration. And some of these will not be predicted because they're crushed tissue. So this does not affect the model performance because you should not include these in the assessment. Saying that, in some foci, I do see that the model is missing some of these areas that should have been predicted as erosion ulceration. And so for that, the recall or the sensitivity of the model will be affected. Now, if we consider that on the entire slide, kind of looking through the entire slide and making sure that we account for the entire area that should have been predicted as erosion ulceration, then based on that assessment, I would give that an 81 to 90%. So just make sure that you're looking at the entire region that should have been predicted as erosion ulceration when you're assessing recall or sensitivity. For precision, because the model is not overcalling erosion ulceration in any areas that it shouldn't, then precision, or it's picking up all the areas that it's picking up as erosion ulceration are truly erosion ulceration, then precision is really excellent, between 91 and 100%. And I would kind of reiterate the point where I mentioned that when you are assessing a substance and you see undercall or overcall of a certain substance, this usually will affect another substance. So you can see there is overcall of lamina propria here in areas where the model undercalled erosion ulceration. So just keep that in mind when you're assessing the model performance. And I will stop here and see if we have any questions. Please, if you do have any questions, put them in the chat and I'll be happy to address them. Or if you come up with any question on a later stage, please reach out to us and we're happy to address these. You will expect to get an evaluation test with some kind of overlays to assess the model performance. And based on that job, we will have people who are proficient to go ahead and assess the performance of IBD-Explore as we deploy it on future data sets. Okay, so I don't see any questions. I hope that means that this is clear.
And if there are any, just go ahead and send them to the path support email. that you
Absolutely.
always reach out to, and then I'll pass the questions along to you, Fedaa. So
Yeah, that sounds great. So again, thank you all for attending, and we really appreciate your involvement in this.
thank you everyone for joining. Have a good day. And we'll send out this recording afterwards. Have a good, bye.